The Naples Daily News would like to welcome Dr. Joseph Gauta, founder of the Especially for Women group practice and Florida Bladder Institute. His clinical expertise and achievements in medicine have garnered him numerous honors, including the Lewis Port Award for Surgical Excellence and the Vitals.com Patient Choice Award. Dr. Gauta also serves on the faculty of Boston Scientific Pelvic Floor Institute and also as well as Olympus American, a leading manufacturer of surgical devices. While Dr. Gauta's many accomplishments have been on the national scale, he has also been recognized locally in the Gulf Shore Life's magazine, Who's Who in Medicine. Here to answer your questions regarding female urinary incontinence, please join the Naples Daily News in welcoming to the stage, already up here I might add, Dr. Joseph Gauta. Thank you very much.
I'm a medical doctor and a board-certified obstetrician and gynecologist, and also a urogynecologist. And through my practice that I am part of the Florida Bladder Institute, I'm going to talk to you this afternoon about specifically female issues regarding incontinence, urinary incontinence. So I mentioned something before, I'm a urogynecologist. Well, what's a urogynecologist? You may not have ever heard that before. Well, a urogynecologist is a gynecologist like myself who goes through training and then goes through further specialized training in urology to learn about and understand fully the entire female pelvis, meaning that all of the organ systems in the female pelvis, the gastrointestinal, the urological, the female system of course, the musculoskeletal, and the nervous systems are part of what I do. And a urogynecologist is that one specialty and subspecialty that is uniquely focused on the female pelvis only. We do not take care of men, we only take care of women, though much of what I do is found in men and women alike. So today's lecture is actually universal, though as a urogynecologist I treat only women. In 2001 we finally defined what incontinence in women means, and there are quite a few different types. Urge urinary incontinence, it is exactly what it sounds like. It's the type of leaking that occurs when a woman has an overwhelming urge to urinate and can't hold it back. That's the type of leaking that occurs. Stress incontinence, which used to be thought of as the most common, but I think is now the second most common in women, is that type of leaking that occurs when some type of stress is placed on the bladder. A cough, a laugh, lifting a weight, lifting a baby, lifting a package, dancing, jumping, laughing, giggling, whatever. Obviously, any type of incontinence is annoying, but the reason these things are important is because the treatments are completely different for all these different types. And last but not least, most women, I would go as far as to say most women, have a mixture of the two of them. And that's because we are not separate physiological and anatomical beings. Everything in our pelvis is connected, and that's why the subspecialty of urogynecology was developed, to be able to understand all the different organ systems that are affected by these problems. It's predicted that about 18 million women, and I've seen studies that say a lot more than that, have urinary incontinence in the United States alone. 18 million. And two-fifths of these women wait about a year to consult a physician. Another third waited almost up to 5 years to consult a physician, and another quarter of them wait more than 5 years to figure out what's happening with them. It's not an easy thing to talk about. I mean, it's easy for me to talk about, I'm on stage, but it's not easy for my patients to talk about. It's not easy for my mom to talk about, or my family or friends. Only now, while we're making patients more aware of these things, have we started to see how common the problem actually is. This estimate here this is kind of an old estimate from 1998. I've seen some latest estimates from 2006 and 2007 saying that, that not $26 billion of impact to the United States economy, but lately I've seen an impact of urinary incontinence on our US economy of over $40 billion a year. So, there's a lot of incentives for drug companies and manufacturers to help figure out the problem while the rest of us are talking about it and trying to do something to help ourselves. This is a list of the most embarrassing things to talk about with your physician. As you can tell, number 5, urinary and bowel incontinence. By the way, bowel incontinence is another problem I deal with. Think about talking to someone about urinary incontinence, actually admitting to someone that you leak urine. Imagine talking to someone about leaking from your backside. How embarrassing that would be to talk about. So if we think that women wait a long time to talk to their doctor about urinary incontinence, I'm sure that studies in the near future are going to show that fecal or bowel incontinence is going to be even a more hidden problem. Let me tell you about stress incontinence. Stress incontinence occurs, as you can tell, when some type of stress is placed on the bladder, some type of abdominal stress like sit-ups or lifting something or coughing. Basically, it used to be thought of as the most common form of incontinence. This is in question right now. It almost always occurs after childbirth, and the reason why is because childbirth causes damage to the female pelvis. It causes some of the support structures like the ligaments and the muscles to fail, and then the bladder and the urethra drop, and that's what causes stress incontinence. Other factors include pelvic surgery like hysterectomies, age, chronic coughing, constipation, and of course our friend menopause. As a matter of fact, in my office, we see a large increase in the patient population at around the time of menopause, which the average age in this country is about 50 or 51. That's really when we start to see a lot of our patients coming in with this problem, though we've dealt with this in the early 20s too in our patients. There are a lot of things that we can do for this problem. Some of them are very conservative, easy, safe, and simple. For example, plain old exercises, which everybody probably knows about. Those squeezing types of exercises that we call Kegel exercises might very well help, or at least, if not help, they might slow down the process so that it's not getting as worse as quickly. We use vaginal cones and biofeedback sometimes to help kind of strengthen those muscles, in addition to the exercises you do at home. There are these things called pessaries, which are kind of like a pillow in a pillowcase, or dentures in the mouth. Basically, a pessary takes up space in the vagina so that the bladder can't fall down. So just like a pillow in a pillowcase, you can't turn it inside out. Same thing with the pessary. If something's in there, well, nothing else can be. So that's the way that pessaries work. They're not the most comfortable things in the world, but they do help some people avoid some of the procedural treatments for these types of problems. One of those is bulking agents, right here. Here's a little picture of a syringe with a particular type of bulking agent, and what that is, bulking agents are the same chemicals that women use to kind of thicken up their lips, or maybe to get rid of some crow's feet here. Not Botox, but fillers in the face. We use the same thing in the bladder and the urethra to help thicken and strengthen up the muscles so that kind of the doorway of the bladder stays a little better shut. That's the idea of that. There are also surgeries. These types of surgeries have absolutely transformed my specialty. As a matter of fact, I think because of sling surgeries and how successful they are, the subspecialty of urogynecology came about. And slings are kind of what they sound like. They're like little hammocks, little pieces of material you put under the bladder and the urethra to permanently lift them up. They're done through a little tiny incision about 1 inch big on an outpatient basis. And as a matter of fact, we're going to start doing this in the office. So these are fantastic things that are fantastic for particular people, not everyone, and only for stress incontinence. On the other hand, overactive bladder, which I really think is the most common type of problem nowadays in women, occurs for different reasons. It's the first or second most common form of incontinence, and this occurs at any age. We see this in teenagers when they start getting their menstrual cycle, and it has to do with hormones, it has to do with medications, it has to do with the nervous system, and it has to do with the habits that people form around their bladder conditions. The risk factors, as I said, nerve damage, infections, even pelvic radiation for diseases of the pelvis like ovarian cancer or cervical cancer or uterine cancer. Sometimes we can help people by just basically talking to them. Actually, that's what we do with every patient. We talk to them first. That's the first and most important thing. And sometimes we find out that all we have to do is help them understand a little bit about what they're doing to themselves. There's a little piece of paper over here, and I'd encourage all of you to come over here to this table because there's a lot of good information for you. But there's one in particular somewhere over there regarding, I think it's under this white stack of papers here, regarding how much water you should drink per day. There's a great little National Geographic article stating that the guy that wrote the article did extensive research to find out where that 8 glass of water thing a day came from. He can't find it. It's not in any single study. It's not in any single book. Where this rumor started, nobody knows. So the whole idea is that you should only drink if you're thirsty. We already have the perfect mechanism to help us understand whether we need to drink fluids or not, or water. If you're thirsty, drink. If you're not, don't. Unfortunately, sometimes people cause urge incontinence to themselves by drinking too much. So sometimes my job becomes really easy. I almost feel embarrassed charging someone when I tell them all you need to do is drink less. But there are many other reasons for it. There are a lot of behavioral things that we can help control, like limiting the amount of bladder irritants, caffeines, and cigarette smoke, and Diet Coke, and sodas, and stuff like that. Acidy foods, all of those things affect the bladder and can cause urgency and frequency. Sometimes all we have to do is kind of retrain people with their habits. Meaning, if you get into the habit of going to the bathroom every hour, you're going to go to the bathroom every hour even if you don't have to. So sometimes we can help, using avoiding diary, help people kind of stretch out their bladder timing. I know people in Naples that know every single bathroom in Naples. We call it toilet mapping. It's true, there's a word for it, toilet mapping. So sometimes we can just get them to correct some of these things that have caused their bladder to shrink, or their nerves to become hypersensitive in the bladder. It takes a little work sometimes, but it helps people to avoid the other things that I'm going to talk about right now. Sometimes we can use biofeedback and muscle training to help them hold their urine in a little bit better. We call this pelvic floor rehab. It works wonderfully well, and it helps people avoid medications. But really the mainstay of urge incontinence, the mainstay of the treatment regimen is medications. Basically, a once-a-day pill, and you've heard many of names like Vesicare or Detrol or Enablex or Oxytrol. There's half a dozen of them. They keep the bladder muscle from spasming. So the idea is just like with a pulled muscle in the back when you take a medicine, well, when the bladder is overactive, we get it to be normally active, so we relax the muscle with medications. But the problem is those medicines are very expensive, and they have side effects like dry mouth and constipation, and you have to remember to take it every day, and oh gosh, they interact with other drugs. They're not easy to take, unfortunately, but they do work. When they don't work, or when someone can't take them, we have other things. We can actually affect the nerve that goes to the bladder using a method called sacral nerve modulation. We basically put a little tiny pacemaker here in someone's hiney, in the chubby part of their hiney. Just like when we put a pacemaker in a person's chest for their heart nerve. We can affect the bladder nerve just like we can the heart nerve, and we can tell the bladder nerve to calm down so the person's not going to the bathroom so often. Or it helps them to get their urine out more effectively, or it keeps their urges down, or it keeps them, it's wonderful. We can do a lot with it basically. And this is an outpatient procedure. It takes 20 minutes to do. Half of it's done in my office and half of it's done at the surgery center. You're awake, you walk in, you walk out. It's absolutely wonderful, and it has an 86% success rate for urge incontinence. Here we go. I know there are a lot of plastic surgeons out here, so I hope they don't start throwing tomatoes at me, but we can actually inject Botox into the bladder muscle to relax it also. Botox is a muscle relaxant, botulinum toxin. Well, anyway, we do that same thing in the bladder, and it relaxes the muscle. It works great. The only problem with it is that it's temporary, just like it is in the face. So every 6 to 12 months or so, these patients have to come back for a quick 10-minute injection, which is not the end of the world, because it works so well. But it's not as easy as having something done once and then forgetting about it. I like this guy. The title of my talk was To Pee or Not to Pee, so this guy answered the question himself. Sometimes we do things to ourselves. Sometimes we can figure them out ourselves using behavioral modification or little changes in our diets if we can figure out what that is. And sometimes you need the help of a urogynecologist. And that's me. So if there's anything that I can do for you, and definitely I'm going to answer questions now, but if there's anything I could do for you, my card is on the chair and along with a little pamphlet, and I'd be happy to talk to you or your friends or family or whatever you need. Thank you.